This program is brought to you by the Forbes-featured Freedom Hub Health Plan, the alternative to overpriced and restrictive insurance. The Freedom Hub Health Plan is exactly what you need. By Frequency Medicine Associates, supporting health professionals and laypersons with safe and effective advanced telemedicine-like technology that can scan and help rebalance the root causes of stress and illness. By the Planet Lockdown film, which can be seen on the Freedom Hub's Rumble channel along with many great speakers. And by The Pavilion, a 21st century community hub that brings together many of the disruptive innovations featured by the Freedom Hub, including direct pay healthcare, farm-to-table dining, TED-like Freedom Hub talks, and more. Visit your-mp.com/pavilion solution for details. It is the 11th of January. Happy New Year. It's our first show, right, Charlie, for the 2023, which I know is going to be an amazing year of positive change and all of these things we talk about and our wonderful guest. We are making progress. For those of you who are new to the show, you can go to our website to sign up, subscribe, see who our past guests were, learn more about what we're doing. And the address is your-mp.com. And if you come over here, you click on the home page down to webinars, and it will take you over to here, the webinars to connect us. You will see who our guests are. We recommend you do subscribe here to both if you're interested. The Freedom Hub webinar Zoom on Thursdays is more policy oriented, more freedom oriented, libertarian, and so forth. And then today, Wednesday, health, biz, and politics, really about how we can move the system forward, more health freedom, more consumer choice, better working conditions for doctors and medical professionals and everything else. We really cover a lot of ground there. And down at the bottom, you will see our upcoming guest. We have Pamela Nygaard, Functional Assessment AI next week, and Brooke Jackson. Charlie might tell us more later about them and where our platforms are. So you can go to BitChute, Brighteon, occasionally YouTube, if it's not too censorship, depending on what we're talking about. So with that, let me jump back over here, stop my screen share, and turn it over to you, Charlie, to introduce our guest, Dr. Johnson.
Gladly, Jim. Thank you for that. Welcome to everyone. And yeah, we like to take a long break over the holidays for Christmas and New Year's, and start with the second week in January. We've been doing this for 5 straight years now, every week except what we call our holidays. And it's been great. At my Substack, which I put in the promo for today, I put the top 10 or 15 health freedom shows, or Freedom Hub shows for health, in terms of view count. I did 2 Substacks. One was the view count, and the other was the best shows, which was my opinion. And we do like to push the envelope because Jim is the entrepreneur behind Pavilion, which is trying to upgrade the idea of clinics to have more of a holistic approach. It was Epcot's original vision from Disney. And Forbes featured how my brokerage combines sharing with health savings accounts, and I work with the Wow Cash Appointments app and other ventures to try and fix the system around cash, which I think is the secret sauce to get to a real market in healthcare. And we like to feature every week the best leaders. And I've been wanting to get Nikki Johnson on here for a long time. And occasionally my brain reminds me that, oh yeah, I got to follow up with this leader. And Nikki's got a nice resume. She's a pediatrician in Cleveland with the Rainbow Babies clinic or hospital. She'll clarify what that is. And she's been involved with 2 groups, as far as I know, Free to Care, which is David Balot's huge coalition of doctor groups. And I think she's more involved directly with Physicians for Patients. And, looking at a few articles about her, I came up with a couple of things she's really focused on. And of course, she's more expansive than that. But she really has nailed what is called the corporatization of healthcare, the cartel. And insiders have heard a lot about these middlemen for expensive drugs, pharmacy benefit managers, and she'll talk a bit about that. One example is if a certain drug is on a formulary for the rebates, the kickbacks that these PBMs get, that could end up overriding the prescription from the doctor. And as a patient, you may not get what the doctor is actually recommending for purposes of corporate profits. Then in the market, there are these group purchasing organizations meant to help hospitals and nursing homes save money on their supplies. And there are some cross membership in boards that may offset any savings. So again, corporatization, is it really saving money? Is it improving quality? Over the years, we've had people talk about sham peer review. Dr. Singleton is on the call. That's a big problem and complaint with the AAPS. Dr. Wallen and others have talked about the replacement of doctors in hospitals with physician's assistants or nurse practitioners who may not have the quality you're looking for if you're panicked in a dangerous, catastrophic health episode. We've talked about the insurance companies with their scam on minimum loss ratio, which incentivizes them to collude with hospitals to game reimbursement. We know insurers use networks that exclude the best doctors. Regulators are targeting honest docs and targeting competitors of insurance companies, and I'll stop there. There's a whole litany for Nikki to kind of tell us what she thinks about this whole corporatization and the cartel we've ended up with and what the answers are. So Dr. Johnson, take it away.
All right. Thanks for having me, Charlie and Jim. I've been looking forward to this too. But you went over a lot of things that are responsible for, physician satisfaction in our current profession. And I really want to spend the 20 minutes that I have to focus in on some things that we can actually reform, some things that are actionable. While the PBMs and the GPOs, secret contracts, and all the vertical integration is definitely a key component of things that are causing us to want to leave medicine. Those are huge targets that we need to take out in chunks. And so I'm going to present some of the concerns about, why we have a physician shortage or a supply demand problem with physicians, and talk about what things we can do to help solve that. And particularly things that Frida Care is interested in, and a couple of things that are interest of my own. So let me share my screen. All right, you guys can see. All right, perfect. Okay, so first thing is, I've chosen this topic not only because it's obviously necessary and it needs, it's much needed in, for healthcare reform, to actually make any substantial changes. We obviously need doctors if we're going to have people taking care of patients. So obviously, but it's also a very personal topic for me because, as Charlie said, yes, I have been employed by University Hospitals, Rainbow Babies and Children's Hospital. My background is in training is in pediatric critical care. I subspecialize in pediatric procedural sedation, but about 6 months ago, I actually left clinical practice. And so we'll talk about some of those reasons, here, but really I kind of want to focus on the broader problem and solutions that we can make. So first, why is there a shortage? Or, we use the term shortage as sort of a general blanket term, but really is a supply and demand problem that has been identified by not only the AAMC, but pretty much every part of the healthcare industrial complex, I call it. For many, many decades. I mean, most of the people here probably heard in med school that we had a primary care shortage and we had a special subspecialty shortage, but this has been looming for many, many decades now. The latest projections from the AAMC is that by 2034, upwards of about 124,000 and on the lower end of the spectrum, 37,000 physicians will be needed to care for the number of patients that are needing medical care. And of course, that gap gets wider each year, which is very astonishing to me that they can't, hone it down and be a little bit more specific. But also that upper number keeps growing. So we'll talk about what's being done about it now, what they are attempting to do about it, and then what reforms are actually necessary and actionable. So first off, of course, we have an imbalance of supply and demand. So we have an aging population that's with increasing complexity of medical illness, requiring more utilization of our services. And, there's more chronic illness with not only with age, but even children. We are just seeing recent, publications from, I don't know, I'm going to say AAP about childhood obesity increasing extensively just in the first year of the pandemic. And, the AAP unfortunately puts out their solution is a pharmaceutical agent, which is just astonishing to me. But yeah, there's less more obesity and chronic illness that not only comes with age, but just in general in our population. So we're needing more doctors. And then once the ACA took effect, there was increased utilization because more people were insured, or at least covered. But what's the problem? We don't have enough doctors. We're not producing enough doctors. They're not training enough physicians. There are not enough physicians that are working in areas that are needing doctors, for example, in the rural care areas. And part of this is, the lengthy medical education and training that we have. And then on top of that, you have a huge decrease in the workforce of physicians. Not only are the majority of physicians that are almost the majority of, almost half of the physicians that are currently working in the workforce over 55 years old, but they're people, the FTEs are declining in pretty much all age groups, even those under 30, under 50. People are cutting their hours, and they're retiring or leaving the practice altogether to pursue other non-clinical areas, like myself. We like to use the term the great doctor exit at Frida Care. There was a 2018 survey published showing about 54% in all age groups were considering retirement in the next 5 years. And this 2021 Mayo Clinic survey that was published was really a survey of all healthcare workers, not just physicians. And it was more predominantly focused on COVID-19 and, its related causes of the doctor exit. But it did show that about one in 5 physicians and the almost 3,000 doctors that were actually included in the survey said that they would quit medicine, quit their current medical practice in 2 years. And 1 in 3 would cut their hours within 12 months. So that's a huge number. And then there was a 2022 Medscape survey of about 13,000 physicians, and 47% of them were identifying as having burnout. Burnout has been quite a buzzword. There's been a lot of recent work done in investigating the causes of burnout. And The list is here. It's massive. Too many bureaucratic tasks, EHR, macro MIPS, prior auth, MOC, all of those things and more. Too many hours at work, not enough time with family. A lack of respect from their patients, a lack of respect from employees, employers, and colleagues, using terms like all-encompassing terms like providers or caregivers, verbal abuse and bullying by patients, insufficient compensation, surprise billing disputes specifically in specialties like anesthesiology and emergency medicine have been huge, and cuts to Medicare are also huge. And then overarching, there's this lack of independence and autonomy that's driving physicians out. So all of these concerns are what? They're systemic problems. And so many of us would argue that they're societal problems. The bottom line is, burnout, like all the other reasons that we have in this care gap, is a symptom of greater systemic and societal problems. So even the AMA Vice President of Professional Satisfaction, which is a very interesting title, but Christine Sensky did publish that while burnout manifests in individuals, it originates in systems. Burnout is not the result of a deficiency in resiliency among physicians. Rather, it is due to the systems in which physicians work. So that means if the problem originates in the systems, then the solutions really need to be to fix the system. So really, what's being done about it? Are we realistically addressing these concerns with systemic changes, or are we just kind of putting Band-Aids on things to try and increase the supply of practicing physicians and nurses also, for that matter? So we'll see what's being done. So the AAMC has been surveying medical school enrollment and kind of following trends for many, many years now. And along with all the medical colleges have set out to increase medical school enrollment by increasing the number of medical schools, increasing slots that are open, and also playing specific focus on primary care training and rural tracks. And they've been successful with that. With increasing enrollment. But, and that's fantastic. The problem is with, primary care in rural areas, there's lots of people who prefer not to work in those areas because it's a lower income to debt ratio for those specialties. And really, again, not a lot of reimbursement. And just sort of that stigma that they're not being, the sexy subspecialty. But it's not just primary care where we need doctors. We need them in all specialties. So how do we do that? We need to, now we got all these med students. Where do we train them? Great. Okay. We have residency for training, so that's at least 3 years of time away before we actually, have a, doctor that's full-fledged out and working and practicing, taking care of patients. The Congress was smart enough to cap funding on GME, and back in 87, I think it was 97, sorry, which increased the gap between the graduates applying for their availability of one of their first and second year residency positions. And that has created what we call a bottleneck that has slowed down the number of, it has increased the number of applicants that are graduates of medical school that are just sitting out there not working and not getting any PGY-1 positions to train. So, and we're only seeing that grow and expand over the years since about 1970-ish. And that was the mid 70s, and that was even before they capped. So one answer to that is people say is to increase more training spots. And that actually was done and in an attempt from Congress. with the Resident Physician Shortage Reduction Act in 2021. They do plan to fund 2,000 new residency positions per year for 7 years. One of the concerns here is we don't really know what is happening with this money. Where is this? How is this GME funding being used? And residents, of course, especially in some of the primary care or lower paying specialties, are concerned about the debt that they're incurring, and with minimum, reimbursement for, during their training. So that's been a big concern for them. So next, with the ACA came this call to increase the supply and use of non-physicians, particularly nurse practitioners or advanced practice registered nurses and physician assistants. The goal was sold as an immediate solution to substitute physicians by promoting more integration in these teams. But mainly it's been done by large PBMs with the backing of large PBMs to expand the scope of non-physicians, basically to allow them to care for patients without the supervision of a physician. With this, we saw pretty much a rapid growth in their certification. We started seeing retail medical chains pop up everywhere, and for the most part are pretty, unregulated practices. Full disclosure, I have nothing against working with nurse practitioners or advanced practice providers. What I do have a problem with is them being promoted as physician substitutes. And many places they are not transparent, especially in large health systems that are using a lot of these advanced practice nurses and PAs are basically telling patients that they are the same as a doctor. And using the excuse because they're the same as a doctor that they can replace physicians. So that is a big part of the problem here. Now, 29 states as of today, 29 states and U.S. territories now allow nurse practitioners to practice unsupervised by a physician, which basically I call practicing medicine without necessarily a license to do so. And whether or not you agree that they can safely prescribe and take care of patients without, is physician oversight is debatable. Yes, there are concerns about improper supervision and collaboration agreements being so varied and not necessarily regulated, or have any oversight over them can also be harmful to patients as well. Are topics of another point of time and discussion. But what really on the topic of physician shortage and giving access to patients, we have to realize that most of these advanced practice nurses have picked up and opened up shop and are working in places where physicians are already occupying. They say that they're filling gaps, but they're actually not working in the areas where we need practitioners to be taking care of patients. So, and then there is one sourced projection that it would take about 10 nurse practitioners to equal the contribution of one family medicine resident, not one full-fledged attending. So are we really oversaturating the nurse practitioner market and draining the RN shortage that we have by promoting more advanced practice degrees and certificates? Are we solving this access to care problem? My answer is no. We still need, primary care physicians taking care of patients. So, and this is just a little chart to just show that they've actually oversaturated that market. And so then, what are the employers in these, in large medical organization initiatives? What are they doing about this? Medical orgs, they understand, they know the causes of burnout. They know that they're systemic. But they're really not doing much to advocate for necessary legislative reforms. The AMA does have has a subsection and initiatives to help solve burnout, and try to collaborate with health systems and large employers to help physicians well-being, but they're really not doing a lot of advocating for the things that physicians need to continue to stay in practice, and to help boost up the numbers of physicians that we need. Health systems are putting Band-Aids on it by starting physician wellness initiatives and resiliency programs. But burnout is not about physician resiliency. It's not about just about physician wellness. Of course, we do need to take care of ourselves. But I would argue, and in the current environment that we have, with most physicians being employed, it's really difficult to take care of yourself in these systems. And that was one of the number one reasons why I left. They doing a lot of mentoring, faculty development, and all of those things, but not really, getting down to the root problems in the system. So what we're doing is pretty much missing the mark. I mean, like a blindfolded archer. So our supply is not keeping the pace with demand. We need a new strategy. We need to increase production, and we need to stop the overregulation, and make some real reforms within the system to help drive physicians to continue to want to practice. So I break this down in sort of three categories. Yes, we do need to educate, train, and develop new physicians, but there's some other ways that we can do it instead of the traditional pathways. We also need to remove some of the unnecessary bureaucracy, and then we need to end demoralizing and dehumanizing practices that are driving people away. Okay. We already talked about increasing the number of residency positions. There are a couple of bills that are sitting, haven't left committee, that are actually good bills that would cover and reverse the 1997 Balanced Budget Act that capped GME funding. But we do need accountability for taxpayer funding that is used for GME training. We need to start thinking of innovative ways that we can do this and produce physicians without using government funding as well, so that we're not dependent on Congress to fund and funds that are depleting. So we do need to get creative about this. We need to, and this is not a free to care position exactly, but do we need to protect slots for U.S. citizens? For the most part in the match, U.S. citizens do, match at a higher rate than non-U.S. citizen foreign medical grads do. But do we really need to make, a strategic effort to make sure American students actually get, who actually get those spots before foreign grads? Don't know. That's something that we can debate over time, especially when you start to think about meritocracy being key. But one of the things that we don't talk a lot about, and a lot of people get shy about talking about, is what to do with that group of physicians who's already graduated medical school but can't get a residency spot. Granted, not necessarily everybody is, picking the residency, that they should be training in. But if you graduated from med school, there's a good chance that you should be either practicing as a clinician or doing some sort of scientific advances, in medicine. You should be employed and employable after you graduate medical school. Otherwise, you've wasted a lot of time and money, and the medical school has done that. We're doing a disservice to people. We're graduating them without giving them the tools that they need to continue their training or continue their career. So One initiative is to license assistant physicians, is what they've been called, or graduate assistant physicians. It started off in Missouri. These are doctors who already, they have loans to pay. They're ready and eager to work. 6 states currently have legislation for licensing. But we need to be, kind of be very specific about how long we want them to practice and what is safe. We don't want somebody who is just, licensed and practicing, without, real certification. I mean, there is a benefit to having initial board certification in terms of protecting patients' safety and benefits. So we need to talk about ways that we can utilize these students, these doctors in a safe way, and try to advocate for them against the AOA, and hospital associations, PAs and NP groups that are opposed to having that competition. Remove the bureaucracies. Okay, DPC, I'm preaching to the choir, I'm pretty sure, with this group, but we need to, it is the way. A lot of, physicians who have left employed practice and opened their independent practice as a direct primary care practice or direct specialty care practice are having that job satisfaction back, enjoying medicine again, and feel free to actually practice medicine again. But we need to foster some unobstructed expansion of DPC. So we need patients and doctors connected to each other in the purest form, without middleman interference. And the best way to do that is through DPC. We need to decouple healthcare savings accounts from high deductible healthcare plans, make DPC membership completely distinct from insurance. And the Personalized Care Act of 2021 is actually one of those acts that can help do that. We need to allow Medicare and Medicaid beneficiaries to use vouchers for DPC services. They should be able to use their own healthcare dollars for the services that they want. The other thing is we need to reverse the ban on physicians owning hospitals that was passed with the Affordable Care Act and passed HR 1330. We need to prevent prior authorizations from impeding patient care. Free to care advocates for specifically for bills that affect seniors, but we really also want to be thinking about every single citizen. Like, no one should have their medical care impeded by a third party. Especially when it is a time-sensitive concern. We need to end mandatory MOC and allow some choice and competition for recertifying bodies like the MBPAS, and I am actually certified by the National Board of Physicians and Surgeons. So we need to promote that as well, and continue to push our hospital executive committees to med exec committees to allow this certification. They've jumped all over the hoops and gotten approval from every single body and regulating body that looks at patient safety and decides whether or not this certification is allowable. It's time for the hospitals to get on board, employers to get on board. And then we need to expose the conflicts of interest within the ABMS certifying boards. The ABIM, the ABP are all profiteering off of MOC, this one product that they're promoting. We need to expose this so that we can make our arguments better for getting some choice there. And, finally, in the list of stopping demoralizing physicians, we need to promote training transparency of all our clinicians. Patients ought to know who is taking care of them. They need to know that a nurse practitioner is a nurse practitioner, a physician assistant is a physician assistant, and a physician is a physician. Know what our training and certifications are and what our qualifications are. They have a right to do that, and they should have a right to be able to choose, not based on the provider list that an insurance company sets out. The Truth in Healthcare Marketing Act that was put forth by Larry Bouchon in 2017 is a very simple, like not even a page bill that would help improve this. And big ones here that I know this audience is gonna really get fired up about is protecting physicians that are employed by hospitals and private equity groups by, restoring due process rights, banning non-compete agreements. And I believe there's an FTC comment period that's coming out soon that will allow everyone to comment on banning non-compete agreements, and this is from all professions. And we need to level the playing field with these disputes over surprise medical bills. We know that the No Surprises Act is not being implemented by HHS as it was intended. It is the Biden administration is for some reason favoring the insurers. We need to find the root of that problem, investigate that, and make HHS do what Congress wanted to be enacted. And that is my short list. I'm sure there's ways where we can add on to this and have a discussion, but I actually presented a similar talk in the Free to Care conference in 2019. And I ended with this quote: "The measure of success is not whether you have a tough problem to deal with, but whether it is the same problem you had last year." John Foster Dulles, who's the former Secretary of State. Why the hell are we still talking about this in 2023? We really need to push and make these reforms happen. That's it. With that, I will take your questions and comments.
Thanks, Nikki. That was fantastic.
Sure.
Can you go back to that last slide? I missed the last two points at the bottom there. We like solutions, so this has been fantastic. It was a HHS word.
Oh, okay, yes. Oh, whoops, sorry. Let me go back because I can't, for some reason, my arrows aren't. Okay. Oh, this one. This one?
Yeah, the bottom, what was that?
Oh, HHS and CMS need
surprises.
to implement the No Surprises Act as it's intended.
And the
And
last two?
Stop
ahead.
favoring insurers in the independent resolution process.
Oh, yeah.
And the current administration, for some reason, are they just the problem? Is it just them? Is this something that's going to end when Biden is no longer in charge, or should we be investigating and figure out if there's other conflict of interest within HHS as it exists? Dependent, no matter who's leading, that's preventing this from being implemented. And one of the reforms suggested by Free to Care in our most recent published paper was actually to start an investigation here. I don't know that that's the answer. I don't know that if there is something specific with this particular administration or not. But it is the problem. I mean, because Congress passed the act. It needs to be held and upheld, and it's with the intended form, and level the playing field so that both the physicians and the insurers get an equal seat at the table in the independent dispute resolution process.
Well, I think if your premise is the problems are systemic, and Dulles is right that if a problem remains in the following year, you really haven't solved it, and you have to ask yourself why. I would say that investigation is needed, and not just to root out politicized decision from Biden and his cronies, but probably Trump and his cronies too. It's and could we guess that the source is the profit motive, or avarice, the lust for power by big pharma, big insurance, big hospitals?
Absolutely. I mean, because CMS, has the control right now, and they are the ones that are allowing the insurers to make the decision and lead the IDR process. So it is so we know for sure the insurers have this vested interest. And the problem with the only reason why I say why I'm questioning whether or not this is a Biden administration problem is because this is one of the last bills that was passed in the Congress when Trump was president. So HHS didn't get to enact the bill until after he was gone. So we don't really know if this is a Biden's HHS leadership problem, or is it something systemic within our Health and Human Services or CMS that is allowing the insurers to win.
Well, folks, if you look at your reactions tab around your Zoom controls, you'll see the raise hand icon. And I would love it if you guys could click that and get the Q&A going. Well, while you get brave to go public with the discussion, I'll start it off. I got 3 questions. Maybe I'll stick with one. So you mentioned the bullying problem, and I think we've had presenters talk about that from a number of different angles. Of course, during the COVID hysteria, patients were bullied into vaccinating in order to get care. We know about the policies some hospitals have to deny organ transplants if you don't participate in the risky experiment. Then we had someone talk about the bullying doctors face from their superiors. And I think that's probably, and Dr. Singleton can probably comment on this, a subset of the sham peer review dynamic that especially maverick doctors face if you don't toe the line. And to me, that's real disturbing because one of the goals we have with Freedom Hub is to restore the art of medicine. This lowest common denominator, standard following, pharma protocol enforced dynamic we have, to me is scary. I want a doctor, if you're right that we need to really demand doctors, I want doctors who are like House on that TV series. I want a maverick experimenting and searching and jogging his brain to figure out what the heck is wrong, especially as you mentioned the chronic disease epidemic. That's the epidemic. That's half the country, and it's out of control, and allopathy is not solving it, right? So we need to have some art of medicine going on here. If you're going to comment
Charlie,
on
there's 2 points that came from that. So first off, yes, billing is happening in hospitals, and it is one of the big reasons why I left. There's some not so overt stuff that's happening that you can kind of bring that you can't really bring into a lawsuit, and really to be able to advocate for yourself. And that's partly what I experienced, because I stood out. I'm always very vocal of what I believe to be true. And I questioned and challenged a lot, particularly during the pandemic, when policies were steering, in a certain direction, and people weren't allowed to question it. What was perceived as scientific consensus. And, I was asked multiple times throughout the last couple of years whether or not I really still wanted to work there, and just for asking questions. I was actually specifically reprimanded for going against the American Academy of Pediatrics recommending the vaccine for young males, or mandating, even suggesting that it be mandated boosters and all. And so, I don't. I just felt like the pandemic was illustrative of the types of things that are going on in academic medicine, and sort of the overarching big health cartel. And it showed how much our health systems the academic medicine, medical organizations, and government agencies are working together against us as a people. And we've seen a lot of this stuff come out with actual evidence with the release of the Twitter files. People have been paying attention to that. So that is, a big concern. And I can't, somehow I'm just blanking on the second part of what you said too, because I think that was a little different.
Well, I'll come
than
back
the
to
bullying
it.
topic.
I'll come back to it if I remember it myself. And I can thank you, Nikki. You just went public with something that is emotional and important, and I think resonates with a lot of our fans and friends, because whether on this health episode or our regular Freedom Hub episode tomorrow is a bit more expansive, we've hosted a lot of doctors in your shoes. Dr. Bowden, I can think of so many. And, Dr. Merrick, at the Norfolk Centera invented the sepsis protocol, and he was a teacher of the year in medical school, and he got drummed out of his position because of his frontline protocol that he kind of led the creation of. And his trauma led him to sort of question the entire allopathic system. And I think you're in a good place because, some of us in this call are in health payment. And Mark Aubrey, I don't know if you want to unmute yourself, but, through health payment reform, we are pushing the integration of primary care. And we're working with lots of allopaths who are open to this needed change because, as we have babies in hospitals and get bullied by pediatricians to take this or that vaccine, and we're saying, no, thanks. We actually read the science and don't believe your nonsense anymore.
That's the thing is I feel like it's okay to ask the questions. It's okay to it's okay to question things that you're being told, flat out is the truth, and advocate for yourself and advocate for your patients. But the inner circle hasn't made it that way, and it does make it difficult for physicians to advance in their career in academia. I being a pediatrician, there are some things that I do think there's benefit to public health with childhood vaccinations, but there are questions that need to be answered, and there are people who want to know those answers. And what we do is, by denying them outright, is to push people away and make people a lot more reluctant to get any kind of treatment or believe what we have to say. The second part of what you said that made me that got me was, I think there's been so little focus on the well person that and keeping people healthy, and much more focus on the sick and treating the sick. That is also turning people away. There are people who want to be healthy and who don't want to get sick in the first place. And we've steered away from that part of medicine, and why, one of the reasons that called us into the practice in the first place. And so those are, kind of my big takeaways that were, that are from the pandemic. And, everybody on this call is going to have different views about specific medications, specific treatments, about vaccines. But what we really need to be having, what we need to fix is giving doctors and patients both the voice to actually question, the ability to make individual decisions that are based on their own personal needs.
I'm just going to jump in and say, I guess the quick answer, as you know, is being healthy doesn't pay.
Absolutely. Being healthy doesn't pay. That's why primary care doesn't pay. Doing a well exam is,
we need new models. Absolutely. I think Linda, you
need to be thinking outside the box. All right. I see quite a few hands. Bob, Linda, I know you want to say something.
Linda was up first. Let's get her.
Oh, Linda.
Yes,
okay.
First of all, to wish to all of you a better new year. I don't use the word happy, has no sense anyway. My question to you, because I am an activist against digital medicine, which they want to implement to mandate everywhere. What is your position and what are you going to do to fight against this crime, scandal? I'm listening to you.
Well, Linda, I do think that digital medicine has a place. And I think that we have to take advantage of capabilities of technology for people who actually want it, but people who actually want to see a clinician in person should also be able to do that as well. I struggle though with, where areas where doctors are needed, where they're not really going to practice. And rural areas have been suffering this problem for a really long time. And I think telemedicine has been helpful. There's also been a lot of innovation that has been beneficial to patients too, to keep them from actually taking days off work. Just for example, I got diagnosed with sleep apnea last year, and how I did that is I did an online, I signed up online, I did the test at home. I had no other concerns about sleep disorder. It was just whether or not I had sleep apnea that I wanted to test for, and I could actually do that. And I got my report over a call, with an expert and clinician, and I got my, CPAP machine ordered and everything. I did not have to schedule an appointment. I was able to use my HSA to pay for everything. And I got the care that I needed. And so I think it's important that we are open to these types of innovations, but there's nothing like touching a patient, seeing a patient's face, not behind a mask, and talking to people and engaging with people up front. So that to me is becoming a lost art. And I hate that part is happening as well. So I honestly, I can't tell you that I know the answer to that one.
Thank you.
I just want to jump in on that. I think that digital medicine is fine. I mean, AI, digital medicine, all the great advances we're seeing in the world are wonderful. The problem is who's pushing the buttons and controlling them. On the back end, it's what are the intentions behind some of these people? Joe Biden, apparently I just signed a bill yesterday, I think, that puts all new cars are going to have a kill switch. I mean, we might be seeing that in patients one day. This is, it's crazy. Yep. Anyway.
Sorry, Jim, the most unpredictable thing on earth is the internet. Finish. Well, okay. I was 2 days without internet.
Well, that's Baltimore,
okay,
I'm afraid. I don't know. Okay, let's go. Dr. Campbell, I know your hand was up there.
Hi, Nikki.
Hi, Bob.
Hi. Nikki presented about 15 policies which absolutely stink, and it's obvious that they absolutely stink and create problems. And so, and of course, she's always been, a informed voice of clarity who's working for the people, which is so rare. So she has these 15 things, and Charlie and Jim, I'll put this to you guys as much as Nikki. There's one common thread. Healthcare is now 20% of GDP. You have big corporations going to our politicians and saying, we'd like to have this policy because it's good for us. And the politicians are doing it. And so how do we regain control? And maybe the best argument for free market healthcare, getting patients to have the dollars again, is the patients will be able to follow the sincere voices and not necessarily do what the government says. There's only about 8% of kids are vaccinated. I have a 16-year-old boy, and every time I look at the metrics, I'm like, this mRNA vaccine is just not in his best interest. So somebody out there is not following the narrative. They're probably silent. But anyway, how do we fix the politicians so that they don't listen to the corporations, Nikki?
Yeah, money. I mean, that's really where that's what politicians answer to money, funding. Who's gonna fund their campaign? And if we're not working together to change their minds, help them campaign with dollars, they're gonna listen to the corporations. The other piece is the corporations have lobbyists that can go up there every single day. Physicians have to work. We don't have time to be, sitting in a meeting, with a politician. We don't activate enough. And some would argue we can't necessarily. We also don't, sit around and form, I guess, collaborations that are going to stay intact. I mean, we'll talk about our problems together, but when it comes time to action, we don't necessarily support one another. And that is something that needs to change. So I don't know how to, that we could have a whole show just about that, I think.
We need to get Charlie to go down there and tell him what the deal is. Charlie, can you do that?
You have to realize politics is about power. Politics means how you organize society. And no matter how limited you think you can get government, it's always going to be controlled by the powerful, not you. So you have to get a mindset change that democracy, like Churchill said, is the worst form of government except all the others, and it's a weapon of the powerful. So you have to limit it, put it in a box. So I'm about to propose for National Health Federation a devolution plan to actually devolve most of the federal health apparatus to the states, because systemically you have to get the states competing on what they're going to do to support the population, to police abuse, and if you can, Montesquieu said to divide government. So we'll talk about that more. I do want to share my screen before you run out of time to solicit your interest, Nikki and Dr. Campbell, in one of National Health Federation's campaigns to, oh my gosh, it's not showing. Let me see if this will work here. And if not, then we won't see it.
The internet.
You mentioned the corruption of one of those sort of certifying boards. And in Oklahoma, there's a bill to escape licensing if you follow the criteria of a registered certifying organization. This comes out of the Goldwater Institute. And if you don't like the criteria of that certifying org, you could set up a new organization that certifies, register that, and then the government wouldn't do anything. Folks who want to remain licensed can follow that path, but the Attorney General would just prosecute fraudulent misuse of the criteria in the certifying org. It would create a race to the top. So this is at thenhf.com/campaigns, and I'll put that in chat. It's big picture reform. It's one of those, it ends licensing. It allows licensing to dry up in the vine, and you would have a free market, and you would market your certifying org. Nikki would start a certifying organization. Patients look for our brand. We have a very strict process for certification, and so this is one of those big pictures. It's like repealing CON, certificate of need, to allow better hospitals. If you end licensing by allowing a competitive certification dynamic to exist, then you create a race to the top in quality for all occupations. So this is in Oklahoma. Every entrenched interest hates this bill because it ruins their monopoly. Because certifying orgs right now collude with licensing orgs. It's all one integrated mess for the cartel. So at this website, I'm trying to find systemic changes, and I'm going to try to get doctor groups to support it.
Yeah, I'd like to look into this, because I think there's a little bit conflation there with the certification and licensing, because they are two separate entities, but where they do meet is in the Interstate Medical Licensing Compact, where doctors can get a medical licensed practice in multiple states. They still, have to apply, kind of separately and pay fees to each state, but they at least, have one central body that, has all their information. And so it's easily transferable, but to participate in that, they're required to maintain their certification with the MOC product from the American Board of Medical Specialties, that product. And so it does not allow any competition for recertification. So that is one place where the two meet. But I'm happy to look into what you just shared.
Thanks. And we're running out of time, but I know Mark has a question. And then my last question for you, you can answer after Mark, is how do you fund GME, which is graduate medical education, without taxpayer funding? That's an interesting idea. Mark, go ahead.
Just really wanted to say, Nikki, you're a fun follow on Twitter. I appreciate the work that you're doing. I try to interact with you sometimes, but you have too many fans, so you don't even know who I am. So that's okay. I'm teasing you. But no, I really do enjoy listening to you on Twitter. I think you've done a phenomenal job over the last couple of years of staying strong and fighting the good fight.
Thank you so much.
The comments that I have, Charles and Jim know me pretty well. I'm a pretty free market. I like to call myself a radical capitalist, but I got to be careful because I don't want to get on a no-fly list before being a radical. But I think that everything you're saying and everybody's talking about, the problem is the government, right? Or the people who are incentivized to lock these things down. So
yeah.
What I would say is that what we have to start doing is there has to become some civil disobedience in medicine. We basically have to say, we don't care what your licensing says. We don't care what you're going to do. This person is trained. This person is good. Because at the end of the day, patients want to work with people who care about them and are willing to work with them. And so it's time for some civil disobedience in medicine. And I believe that there's developing what I call a new health economy. And once we realize that the old system is collapsing from within, people are going to try to figure out what's going next. And stuff like what Charles just talked about is brilliant. And we need to start rising up and saying, we're in this together, and quit trying to fix the old system and saying, we have to create a new system because the old system is so corrupt and so broken. We need to do something new. So look for me on Twitter. It's Impact Health is my thing. So I'll be commenting on your stuff and cheering you from afar like I have been for the last couple of years.
Awesome. Thank you. Thank you.
What about that as we wrap up here, doing both? Some folks say, don't bother with politics. It's too captured by the special interest, which is true. But does that mean you give up? And then also, do you just focus there, or do you do the work for people like you, brilliant, caring doctors? You're the kind of person we actually want in the system, Nikki. How do we erect this independent system at the same time?
Yeah. So, honestly, if I had, my subspecialty is it's almost like anesthesiology, but it's not quite anesthesiology, because I, would sedate children out for procedures outside of the operating room. Most of the patients in the system, require Medicaid. And it just was impossible. It would have been impossible for me with the current system at 49 years old to start a practice, doing what I do, and, still make a living. So there was so much, kind of packed into my experience, in medicine, and my career that, it was killing me. Physically, I was suffering. Spiritually, mentally, I was suffering. I needed to leave. My husband told me that if you didn't leave, it's going to kill you. So I left, and I am so grateful that I'm able to do that. have been able to, kind of be at home and kind of figure out what I'm going to be doing with myself. But I absolutely hate that I don't get to interact with patients anymore. I do miss that dearly. So my next, mission is not only to help reform healthcare, but to do it in such a way that helps doctors stay. And good doctors stay and want to take care of and take care of patients the right way. And so I think, I'm fully willing and open to work with anybody who wants to do this in a free market way, because that's the only way I think that we're going to be able to pull out of this. I have had some moments of being very discouraged about working with politicians and policymakers, just because of the sheer what do you call it? The interconnection between all of the agencies and medical organizations that are, working on behalf of the people who profit off of the way it's been done by now. I mean, it is a huge system that needs to be dismantled in order for us to actually make any real reforms. So I think the best way is to go around it and do some innovation. So I've seen the DPC people go for it. People who are starting these online doctor hubs are awesome. Leah Wright with her HPEC
Yeah, Houston,
yeah, Leah Houston. Sorry, gosh,
Yeah.
why did I say that right? With HPEC, keeping doctors agency and ownership of our own credentials is huge. So I think that is the way that we need to champion and champion one another. We don't, need to agree with each other's approach, but we do need to be supportive of our freedom to make the approach, and that's kind of where I stand.
That's where a lot of us stand. So Nikki, welcome to our team. We'll help you. You'll help us, and so many are in your shoes. So how do folks reach you?
I'm on Twitter. Not a provider, MD. Pretty easy. Pretty active there, and that's one of the easiest ways. So DMs are open. Getting a lot of requests for stupid spam for Amazon or Bitcoin, all kind of weird requests nowadays. But yeah,
Do you have a
open to
website?
discussion.
You have a website for your group?
I don't have my own personal website, but I do have a Substack, and it's under Nikki M. Johnson, MD.